I will take only 20 minutes, and I will present you the results of this web-based first international consensus conference on mortality reduction in cardiac anesthesia and intensive care. I have no conflict of interest. I have many potential conflict of interest. These are the drug companies I work with in the last 10 years. And this is the paper published in Acta Anesthesiologica Scandinavica at the beginning of this year. It was co-published in the small journal of our hospital that will soon be indexed in PubMed. There were 340 participants from all over the world, many from India. We had 2 years meetings with a small group of experts, and then we had a few months working in the internet, and then we had a one-day meeting here. This is San Raffaele Hospital and University in Milano. Under the cardiological and surgical point of view, you probably know Milano because of Professor Alfieri of the double stitch technique, and there are many other important colleagues working there. So 340 colleagues, many endorsements, including the Italian Ministry of Health and the Expo 2015 that will be in Milano. We started from 120 topics, and at the end, we choose only 10 of them, and these are the 10 topics in order of consensus. 8 of these topics might theoretically reduce perioperative mortality in cardiac surgery, and 2 of these topics can increase mortality. So to be included in this consensus process, a drug, a technique, or a strategy had to be published in a peer-reviewed journal. It must have been a non-surgical technique, and in this paper published in a peer-reviewed journal, there should have been a p-value with a statistically significance and with a reduction or with an increase in mortality. So I'm going to show you these 10 topics. The consensus conference is not saying that these 10 topics are definitely reducing mortality according to evidence-based medicine. They're saying that they are the most promising 10 topics, drugs, techniques, or strategies. Let's start with randomized controlled trials. I'm sure that everybody knows this paper, 2001, New England Journal of Medicine, continuous infusion of insulin in the postoperative period of cardiac surgery can reduce mortality by 50%. So it would be extremely long to discuss this topic in details. You know that this paper has not been confirmed in general ICU, and you know better than me that hypoglycemia can increase morbidity or mortality. But I think that after this paper, all the post-cardiac surgery unit worldwide is using some kind of continuous infusion of insulin. The point is, which is your target and how many staff and how many blood sample can you take to monitor and safely perform the control of glycemia. Probably the target is not 80 to 110, as reported in that paper. That could be dangerous in our routine clinical setting. Maybe maybe the target is 140 or 150. But definitely insulin can be life-saving after cardiac surgery. This is another large randomized trial. Aprotinine is no more sold worldwide after this paper suggested an increase in mortality when using this drug. This drug was loved by cardiac surgeons because it reduces perioperative bleeding. Unfortunately, when a large academic, no-profit, not sponsored study was performed, they confirmed the effect on bleeding, but they saw that the drug increased mortality. And I think you cannot buy this drug in the market anymore. This is also to remember the importance of no-profit academic trials. So these are the only two large randomized trials with the effect on mortality ever published in the cardiac surgical literature. Then there are 3 meta-analyses of randomized controlled trials. Intra-aortic balloon pump is beneficial when given before cardiac surgery in high-risk patients undergoing revascularization. I think that most cardiac surgery centers in the world use this strategy. The point is that the evidence is there, is not so strong, because this is a meta-analysis of small randomized trials, and most of these trials have been performed by the same group. So most probably EABP is beneficial, but there is still need to study this topic and understand which are the patients who benefit most. This is a meta-analysis of small randomized trial performed by our group in Milano and published on the JCVA in 2010. Levosimendan seems to be the first inotropic agent who has a beneficial effect on survival. You know that all the inotropic agents that have been studied before had some kind of non-positive effect on survival. I mean, we use them. I use them every day, but because we are forced to use them because the patient is hypotensive, low cardiac output syndrome, but every time they have attempted to study inotropic agents with randomized trial, the effect on survival and on major outcomes was not there. So this is the first agent that seems to be beneficial in terms of survival. The only problem is the cost. Today it is an extremely expensive drug. And after publishing this meta-analysis, we applied for grants to perform a large trial to confirm these results, and we have now randomized the first 10 patients to receive either levosimendan or placebo on top of the best available treatment. And we are 30 hospitals in Italy, and we will randomize 1,000 patients in the next 2 to 3 years to confirm the promising results of this meta-analysis. This is another meta-analysis of small randomized trials published by our group in 2007 in JCVA. I remember that 3 or 4 of the randomized trials included in this meta-analysis is from our group. And volatile anesthetics might reduce 30-day mortality in this specific category of patients: hemodynamically stable patients undergoing revascularization. I would add in low-risk patients, because the evidence is from low-risk patients undergoing CABG. And remember that this effect is not related to hemodynamic stability. It's just an intrinsic pharmacological cardioprotective properties of volatile agents. At the same time, please remember that there is still no evidence outside cardiac surgery, and there is still no evidence for high-risk patients undergoing cardiac surgery. We published a paper a few days ago saying that in high-risk patients, our randomized trial did not confirm the promising result of this meta-analysis. Only 3 meta-analyses of small randomized trials suggesting a reduction in perioperative mortality in cardiac surgery. So let's say that the most important results of this international consensus conference is that evidence is lacking in our setting. So cardiac surgeons, cardiac anesthesiologists, perioperative staff has not been properly randomizing in the last 20 years. Let's hope we are doing it now. Statins. From a meta-analysis of randomized and non-randomized trials, it seems that even a short course of preoperative statins can reduce perioperative mortality, probably stabilizing the coronary plaque. The evidence is not very high, but most probably within few years, we will have all patients undergoing cardiac surgery who will receive statins at least for a few days before surgery. But we still need to focus on this topic and to study it. And then it will be very interesting to know who will be the one giving the statins, who is the one taking care of the preoperative, or yes, let's say of the preoperative period of these patients. Then we have only non-randomized trial. We have a JAMA paper saying that patients with more than 30% of ejection fraction who arrive to coronary artery bypass surgery with beta blockers have a better survival than those patients with more than 30% of ejection fraction arriving to cardiac surgery and not being on beta blockers. So probably preoperative beta blockers are beneficial in these patients. This is a New England Journal of Medicine paper suggesting that hospitals that start aspirin early after coronary artery bypass grafting surgery have better outcomes than those centers who start aspirin after 48 hours after surgery. But I think that today everybody is starting aspirin early. If you are a patient, you probably would like to go to a big center and to a surgeon who is operating many patients per year. So this doesn't need to be published. This is an interesting paper. After the publication of this paper in the Cleveland Clinic, they entered into the hospital with this paper and asked the surgeon or the anesthesiologist to receive fresh blood instead of old blood in case of transfusion. This paper say that patients receiving blood transfusion in the perioperative period of cardiac surgery survive more if the blood is less than 2 weeks old. And that's it. These are the 10 topics again. This is the percentage of agreement that was reached among the 300 participants through the web. And these are the 8 topics that where we did not reach a consensus, so they were not included in the main table, but most probably they are useful. Clonidine, epidural analgesia with all the problems related to epidural hematoma, phenoldopan for cardiac protection, for renal protection, the best hematocrit during cardiopulmonary bypass. And I would stop here. So I'm sure that you already knew all of these topics. Maybe you didn't know that these were the only 10 topics with some mortality implication in the perioperative period of cardiac surgery. I'm not saying, the consensus conference is not saying that these are life-saving drugs or techniques, but that we should focus on these topics if we want to perform research or if we want to try and implement our hospitals and our departments. These are the large randomized trials we are performing in our country. And next year I will present you the results of this consensus conference that was already taken. And I thank you very much for your attention.
Moderate to severe left ventricular dysfunction, lower the ejection fraction, better is the role of beta blocker. So any data on use of beta blocker in ejection fraction less than 30% who are undergoing bypass?
Yeah, very good question. So I think that if you are not talking about the perioperative period, you're right. I mean, beta blockers are life-saving in patients with low ejection fraction. That paper simply said that when you arrive close to surgery, in patients with more than 30% of ejection fraction, beta blocker therapy is a predictor of a better survival. While in patients with less than 30% of ejection fraction, this effect was not found. But I would like to be beta blocked, even if I am less than 30% of ejection fraction. I think this is a good point. You know that there is a lot of discussion with one big trial, the POISE-1, suggesting that the beneficial effect on myocardial infarction are overcome by an increased perioperative mortality due to hypotension. At the same time, there are the international guidelines suggesting the beneficial effect of perioperative beta blockers in vascular surgery and in non-cardiac surgery in patients at high risk. So I'm aware there is much debate that probably the POISE-1 trial gave too much beta blocker and high dose retard, and so there was a kind of overdose. So probably if you start beta blocking days or weeks before vascular surgery, you're doing something good and you are saving patients' life. If you find a patient in the theater and you start beta blocker in that moment at high dose and giving hypotension, you're probably killing patients. So beta blockers are beneficial drugs, but like insulin, if you give them too much, you risk the life of your patients. I'm not well aware of...
It was in the last week of October or first week of November, right?
Yeah, you're talking about aprotinin.
Yes.
Okay.
Now the tresolol is going to be available. Again.
Will be available.
Yeah.
Okay. So I think that if the patient is at extremely high risk of bleeding, this drug is probably beneficial. When you give it in a randomized way to an intermediate risk population, its thrombotic effects are more dangerous than the beneficial effects.
Well, if I correctly remember, the advisory against the tresolol was increased mortality because of the renal complication. That advisory has been withdrawn by the FDA in the last week of October.
Yeah, I mean, generally speaking, I fear drugs who have a beneficial effect on coagulation. Any drug except tranexamic acid. You have a recombinant activated factor 7A that is working but has not entered into use. We have a randomized trial saying there is no effect. So I think that in refractory bleeding, you can use these drugs, but the patient should be few, and you must do a perfect hemostasis and use tranexamic acid before. I think these drugs are definitely dangerous, but I'm happy if it is back into the market, because I'm sure there are few patients who will benefit from this. The important is that this patient must be few. The pro-hemostatic drug should not be given routinely, with the exception of tranexamic acid. That is even cheap. That is even
Thank you,
a
Dr.
very cheap
Giovanni.
drug.
That finally the interventional radiologist had to take care of. And the third thing is never forget people that have helped you. Because that day I will never forget my second-year GI fellow who, while I stood totally clueless, got the cart ready for me and had the scope in my hand, which obviously I was not able to pass. So just with that, we'll proceed to the second slide. This is again thanking my alma maters. This is Guwahati Medical College where I did my MBBS, and I never forget that. And this is Jefferson Medical College in Philadelphia, where I have done my postgraduate training in medicine and in gastroenterology. It was Dr. Berkowitz et al. In 1957 who first reported significant GI bleed after cardiac surgery. And as you can imagine, they noted peptic ulcer to be the commonest cause. That was the most frequent GI complication noted by him. And he noted that the upper GI mucosal injury was present is as high as 82% of the patients. However, bleed really happened only in 0.6 to 9%. We know today that the commonest cause of GI bleed in the cardiac ICU is stress ulcerations, followed by esophagitis, peptic ulcer disease, arteriovenous malformations, etc. And we also know that various cytoprotective and acid-suppressing agents have been used to treat this condition. Now, why is this topic important to cardiothoracic surgeons, cardiologists, and all this elite audience that we have here today? Besides the fact that these patients that have undergone this major cardiac surgery are very sick, and we as their caretaker cannot take any chances, almost all of them, if not all, are on aspirin, clopidogrel, and anticoagulation of various kinds. I mean, this is the perfect nightmare for the gastroenterologist. You get a phone call, and it's typically Friday afternoon from the CT surgeon. We have a patient who had cabbage done 5 days ago. They're vomiting blood, and their hemoglobin is now 8. And before you can even ask a question, they go on. And they are on heparin, Plavix, aspirin, and let me tell you, we cannot stop any of this anticoagulation. So this is why the topic is very important. And the patient needs to be scoped. They need to be scoped. So let me begin by bringing your attention to a paper that was published from Netherlands in 2000, which was titled Pathogenesis, Risk Factors, and Incidence of Upper GI Bleed After Cardiac Surgery. The authors looked at all the studies which was done to this date, which was about 30 of them. They were all retrospective studies. They were not randomized controlled trials, and therefore meta-analysis could not be done. However, what they noted is the following. They noted that the pathophysiology of GI ulceration and stress ulceration and GI bleed in this set of patients is extremely complex and multifactorial. There is reduced splanchnic and gastric blood flow, which leads to decreased oxygen delivery. There is decreased barrier function of the mucosa of the stomach, and there's backflow of acid causing further damage. Then there is an increased intestinal permeability. Also, these patients have an enormous inflammatory response, which happens just by ischemia and also related to the use of ephedrine, which is used during hypovolemia in these patients. This causes vasoconstriction, damage to the gastric mucosa, ulceration, and sometimes significant GI bleed. Though we do not know a direct correlation between gastric acid and stress ulcer, at least based on this paper, we do know that mucosal injury does lead to back diffusion of acid and further damage. What were some of the risk factors that the authors noted for GI bleed after cardiac surgery? Heart failure, especially class 3 and 4, left ventricular ejection fraction less than 40%, hypertension, valve replacement, anticoagulant therapy, reoperation, placement of intra-aortic balloon pump, prolonged cardiopulmonary bypass time, renal failure, and a prior history of peptic ulcer disease. How can we help this patient? There is only one way, early diagnosis. So, it is very important to have a high degree of clinical suspicion and obviously to resuscitate the patient early on. whether it is the stress ulcer, which is looking a little deeper than the usual stress ulcers that we see, that are luckily for us superficial, or it is the duodenal ulcer in the bulb, or it is an arteriovenous malformation in the stomach, or an arteriovenous malformation in the duodenum. The best way to change the morbidity and mortality of GI bleed is by doing early endoscopy. This is what a Dieulafoy's lesion looks like when it is not spurting blood. I'm sure the audience knows, but Dieulafoy's lesion is an aberrant blood vessel that can be present anywhere in the GI tract, commonest place being 6 centimeters from the GE junction in the fundus of the stomach. And this I put up just to remind all of us that this condition, which is called gastric antral vascular ectasia or watermelon stomach, can mimic gastritis. I mean, this just looks like picture of gastritis. The difference being that the gave, as it is called, really bleeds horribly when anticoagulation is given. And of course, this is important for the gastroenterologist to realize this diagnosis and be careful. So what is the summary of this slide? High degree of clinical suspicion, followed by early endoscopy, and early endoscopy. So this paper that I mentioned from 2000 concluded that though the incidence of mucosal lesions is pretty high in this group of patients, luckily, the GI bleed following cardiac surgery was not that high and was even slightly lower than the general ICU GI bleed. They also questioned prophylactic therapy and whether it was cost-effective or not. And what they came up with in 2000 is that prophylactic therapy should be minimized only to the high-risk patients in the cardiac ICU. They laid some stress on preventive strategies and said that tissue oxygenation should be preserved during surgery and post-operative period. We should try to avoid hypovolemia. We should minimize the use of vasoconstrictive drugs, and we should use vasodilators if need be. Now, all of us know that, take care, that this is easier said than done. However, this was what was laid out. This slide is another picture of Jefferson University Hospital. This is just to remind me that proton pump inhibitors, or PPIs, are not just misused and used in the entire US, but right happens in university hospitals as well. Let's face it, proton pump inhibitors work. They're excellent drugs. So we all tend to use it, and we often misuse it, whether it be in the ICU, the hospital, or in the general office setting. Let me draw your attention to a first study from Beijing that was published in Surgery Today in 2010, and the authors looked at risk factors and prevention of upper GI hemorrhage after CABG. And what was their conclusion? There were 2 risk factors that they came up with. One was advanced age of our patient, and the second was increased extracorporeal circulation time. What they noted was that for every 10 years increase in age, the increase in risk of GI bleed goes up 3.2 folds. And for every 30-minute increase of cardiopulmonary bypass time, the risk goes up 1.3 times. They also noted on their paper that prophylactic use of PPI did prevent upper GI bleed in the face of dual antiplatelet therapy as well. Now, this is the difference between 2010 and the paper from 2000. Another study looking from Japan, which looked at the prophylactic treatment, and this was published in 2005, and they looked at optimal prophylactic treatment in which they had 210 patients, 3 groups. Group 1 got tepranon, Group 2 got ranitidine, which is an H2 receptor blocker, and Group 3 got rabeprazole, which is a proton pump inhibitor. All these patients underwent endoscopy between day 5 to 7 after their cardiac surgery. What was found? 4 patients in Group 1 and Group 2 had significant gastric bleeding, and 2 of them even died of coagulopathy. In Group 3, that was on the rabeprazole group, no patients had significant GI bleed. The other thing that was noted was hemorrhagic gastritis was found in 23% in Group 1, 15.7 in Group 2, and a much smaller number in Group 3, thereby indicating that, yes, PPIs did help. Let's finish this part with a meta-analysis from Taiwan, which was again published last year in Critical Care Medicine, in which they identified 7 randomized controlled trials that covered about 950 patients, and they compared the efficacy and safety of PPIs to H2 receptor blockers. And what did these authors come up with? They did not find a very strong difference that PPIs were different from H2 receptor blockers, either in terms of stress-related upper GI bleeding prophylaxis or development of pneumonia or mortality amongst patients that were admitted to the ICU. This is the picture of downtown Philly in the evening. During daytime, it may not look as pretty. But anyway, this is the Schuylkill River, very serene, and behind these two buildings is the Jefferson Hospital. This is, the 30th Street parking, which is pretty new. So I really would, when you guys, any of you most welcome to visit Philadelphia, just let me know and we can have a ride around the Schuylkill. Let's switch gears and talk about LVAD. We already had at least 2 lectures in this session. What happens with patients with left ventricular assist device and GI bleed in the ICU? We already learned today that it was approved for use in the US in 2008. We also learned that it is a bridge to transplant in the advanced congestive heart failure patients, and also in some it is the destination therapy in patients that cannot get transplant. We also learned these are surgically implanted pumps that provide mechanical circulatory support to patients with severe systolic heart failure refractory to medical therapy. There is no doubt that it has increased survival, maybe by just a few years, as one of our speakers said, but it comes with its own set of morbidities: stroke, infection, right heart failure, and GI bleed. And plus, what happens is these patients need antiplatelet treatment in different forms and anticoagulation to maintain an INR of 2 to 3, and that obviously does not help the gastrointestinal bleed. So there's not a whole lot of data because the device itself is relatively new, but the largest and most comprehensive study to date that I found, which looked at the diagnostic and therapeutic yield of upper endoscopy in these VAD patients who had overt GI bleed, was from the University of Michigan. They looked at patients from 2002 to 2009, and this was just published in last month's Digestive Disease and Sciences. Actually, one of the physicians here is one of my fellows right now who was then in University of Michigan, so I really got to know the nuts and bolts of the study. It was a retrospective study. They looked, all these patients had VAD for at least 1 month, and they all needed to have overt GI bleed with a decrease in hemoglobin by at least 2 grams to be enrolled in the study. So what did they find? 237 patients, 134 continuous flow, 103 pulsatile, 65 patients had VAD and GI bleed, 26 were finally included in the study. Out of 17, out of 26 were males. Now, if you look at the coagulation story, 20 out of the 26 were on more than 1 anticoagulant. The median time from VAD placement to GI bleed was 32 days, and all these patients needed to have overt GI bleed, okay? So what did they find now? One more study before I finish about deep enteroscopy in patients with LVAD. It can be safely performed. I have myself performed quite, a few. Careful planning is needed because you do not want these patients to perforate. It can be a catastrophe. Endoscopy should be extra careful, and a multidisciplinary approach involving the CT surgeon, cardiologist, anesthesiologist, and gastroenterologist is important. So to conclude, GI bleed occurs in 15 to 40% of patients after VAD. Vascular lesions are the commonest cause. Endoscopy is a safe and effective tool, but be mindful that multiple endoscopies may be needed. Dedicated small bowel evaluation, if needed, should be done. Colonoscopy is of very limited utility unless the patient is having rectal bleeding. And obviously, we do need prospective multi-center study to establish evidence-based algorithms as to how to manage these patients. Let me show you some Phillies. I know I'm running late, but Philly symbols. This is pretzel. Pretzel is nothing but it's made of dough with a bunch of salt. So if you really wanted to go on a carbohydrate-rich diet, that would be the thing to eat. It's very famous in Philadelphia. I don't eat cheesesteak, but this is Philly's cheesesteak. If you were to visit Philly, do not leave without eating that. And this is the football team, because as you know, America survives on football. This is our Eagles team, and there is no fan in the world like Philadelphia fan, except the cricket fans in India. I think they are the only ones that are better. And the last slide I must show you is, this is the Phillies team, which is the baseball team. And although we won the World Cup in 2008, we are still celebrating. Thank you for your attention. That's all I have to say.
Thank you, Mrs. Choudhary. Do you think routine use of ranitidine is preferable to PPI? And number two, it's not uncommon for these patients to have intractable hiccups. What is your trick?
So I heard the first question. The first question is, and let me correct me if I'm wrong, that since there has been a lot of controversy about PPI and clopidogrel, do you think H2 blocker is better? Right?
Yeah.
Is that what you're saying? Okay. So we always have this argument with the cardiologist, and as you know, and you're probably aware of all the studies that have gone back and forth, started with a study on the omeprazole. Right now, what we are doing is that if the patient has had prior GI bleed, we are giving PPIs. We are just separating the two. Because I don't think, based on my limited knowledge, that there is a whole lot of difference between one PPI and the other, or a whole lot of difference between using PPI and H2 receptor blocker as far as the interaction with the Plavix is concerned.
Intractable hiccups. What is your trick?
Intractable hiccups, what is the treatment?
What is your, yeah.
Aha, okay.
Trick.
Besides jumping off the nearest bridge, well, you know, you can start by giving something. So the question is, what is the cause of the intractable hiccup? You know, that's very important. You're talking as a side effect of the PPI or just in general?
Whatever.
In general. So we start by giving thorazine, if that doesn't help. But, you know, you just have to make sure that there are no subdiaphragmatic lesions, such as, in this case, it would be a bleed. As long as you have ruled that out, then you can start with thorazine, pray to God, and go from there. The other thing you got to make sure is that the person does not have an esophageal motility disorder, which was misdiagnosed as reflux, because esophageal motility disorders very often present as intractable hiccups.
Thank you.
The Cardiology Society of India tried to correct this by building guidelines on the care of the patient with prosthetic valve. I have been part of this guideline process, and I'll show you what they are thinking of at present. And your comments would be welcome because it is still work in progress. When we get patients like this and they give a history that they've stopped taking oral anticoagulants for a week or more, we just go ahead and immediately, yeah, that's nice, and you can see this one. This is how the patient, we just take them to the cath lab immediately because we know that these are patients who are not going to survive even till the morning. He's just managed to occlude it, even the superior mesenteric artery cannot be seen, and all that is the gut is getting is from the celiacs. So we decided that the first thing to tackle would be the leg arteries. And since this is all soft thrombus, you are able to push your wire and fragment the clot. Some flow could be restored into the right femoral and then very quickly into the left femoral also. You can see that as you keep pushing the clot down, it keeps migrating more and more distally, and you have to just keep on fragmenting it till the body takes over. It's very important to make sure that all the major vessels are open. The renal arteries were full of clot, as you can see on this side, and the same was true for the other side. But it's not very difficult to get rid of it if one is persistent in pushing the clot out of the way. This shows that the superior mesenteric also has opened up. The femorals are flowing well. This patient actually made a recovery because his clot was so big that it didn't go into the brain. But smaller clots go into the brain and they are just not able to recover even. And hopefully, with the help of recommendations like the ones that I am suggesting today, we will have slightly better care of these patients. See, the Indian patients, one more problem is that hepatitis in India is extremely common, and there is nothing happening in the liver in terms of protein synthesis when the patient is in acute hepatitis. Prothrombin time itself is seldom available to patients. Even very reasonably good sized towns with more than 1 million population may not have an INR facility which is accurate. It is still quite common for the person running the lab to make his own reagents and do it in a very, very unsatisfactory way. It's also important to remember that patients who've had a heart transplant have not been cured of even their cardiovascular disease. They are very prone to developing CHF, if not in the next few years, then in the next few decades. And treatment has to be just as it is for patients of large myocardial infarctions, etc. Bioprostheses are being used in India partly to get rid of the problem of anticoagulants, and we are thinking of making a suggestion that any patient who is more than 6 hours away from reliable INR is a possible indication for bioprosthesis. If a metallic valve is being chosen, then one should consider home INR kits. Fortunately, these are quite reliable. Patients who get a bioprosthetic valve require lifelong antiplatelets. This has been shown repeatedly and tends to get omitted. They also are prone to endocarditis even down 5 years or 10 years down when the valve starts degenerating. So the behavior for endocarditis is slightly different than is from metallic valves, which tend to get most of the problems early. INR itself is a very tricky test, and unless we have got a certified laboratory using standard reagents which are very sensitive in ISI, unless you've got automated equipment, because pipetting, clot detection, all these things can go haywire. Equally importantly, unless the process can be done rapidly after collection of the sample. Taking the sample in one place and then transporting it to a central laboratory, this is one test where there will be inaccuracies. We have discussed the availability of genetic profiling. It is not really useful. I have some experience with it. Some of the students have done a thesis on this. It just is not worth doing as a routine procedure. I think we are recommending that patients should be written down in the file as high risk or average risk. Any patient who has had the surgery in the last 12 months has to be written down as high risk for anticoagulation. The reason is a large proportion, much more than 6% per year, of the problems occur in the first year. There is no year as bad as the first year. The patients have just come out of very severe CHF. They may be putting on weight. They may begin to eat. And they may not have received anticoagulants in the past, so nobody knows what exactly they need. The amount they need also keeps changing as they put on weight and get back to normal health. And that's the time to watch. But all metallic mitral valve prostheses are high risk for the rest of their life. Atrial fibrillation, any patient who's had embolism, in spite of taking adequate oral anticoagulants, has got a problem in his coagulation physiology which makes him high profile. So he's just telling you that no matter how well you are doing it, I can still make clots, and that history has to be respected. We promote an INR of 3 for high-risk cases and 2.5 for low-risk cases. A patient with mitral prosthesis who's doing very well and has completed 3 years without having any event is then put as low risk but continues to have a target INR of 3. We've also suggested that the range should be standardized. Everybody accepts that INR within 15% is within range, but we have said the out of range should be up to 30%, and unacceptable INR should be less than 1.8 or more than 5.2. We are sure that more than 5.2 bleeding risks grow up very rapidly. We are also suggesting that if patients have an out of range INR, do not change the dose, because you may find that the INR is slightly low. You wanted it to be 2.8 and it is 2.3 or 4. Wait for the next INR. All that you do is you halve the time at which you will be coming back for a repeat INR. If you keep changing the dose, then there tends to be even more problem. So once you have two indications, the patient is bleeding and his INR is high, you change it. Patient's had a clot and his INR is low, you change it. But if it's just an INR which is out of range, you wait for the next one, you can do it at half the time, and then change if both of them are matchingly low or matchingly high. There is a lot of trials to say that every patient who is high risk, that means metallic patients, patients who've had one embolism, patients who've got a mitral valve replacement, should be on oral antiplatelets. Routinely, they have to get aspirin. If they cannot tolerate aspirin for any reason, the other available antiplatelets are very effective. There are trials to show that they work and they should be given. Once again, bioprosthetic valve patients have to get antiplatelets for the rest of their life. There is good data to say that it is necessary. The guidelines people are trying to say that too much of use of heparin every time the patient is going through something or the other is not very good. If the patient has finished 3 years, has never had oral anticoagulant, never had thrombotic or bleeding problems, tends to have stable INRs, if you need a surgery, a routine surgery, you can stop the drug for 3 to 4 days, check the INR in the morning of the surgery, and proceed. And then the oral anticoagulants can be started as soon as the patient is allowed orally and there is good hemostasis. You may not need to give heparin to these patients. It would be required only for patients who are having thrombotic episodes in spite of good control, or patients who are in their first year. You don't want to take any chances, you don't know how they behave. Same is true for pregnancy. We are recommending that pregnancy should not be encouraged in the first 3 years, and it is acceptable to give them oral vitamin K antagonists instead of switching over to heparin. I know there are concerns about embryopathies. The way to do it would be not to over anticoagulate, set the target INR at 0.5 lower than the usual INR, and let the patient go through the first trimester. All through pregnancy and for 3 months after, the patient will have to have blood tests at half the interval, basically at every month. It's important to understand that if the patient develops TB or seizures, which are not uncommon in cardiac patients, and you start anti-epileptics, the INR changes, but very gradually. You add an anti-epileptic, the drug dose doesn't change immediately. It may take a month or 2 or 3. So INRs have to be checked every 2 weeks, and if the patient goes off drugs, like after 9 months of rifampicin, you are taking it off, the changes in INR will occur after 4 to 6 weeks. So you can't just predict when it will happen. You have to do the INR every 2 weeks. The patients, before they are discharged after surgery, have to be told about hepatitis. If he gets jaundice, he has to stop the medicine and contact the doctor. If they continue to take the drug, we all emphasize never leave it. They have bleeding. And bleeding should be classified as life-threatening, moderate, or minor. I want to make a comment on menstrual bleeding. It is more common a problem than most of us bother to attend to. If we go into it, it can be quite a havoc and a cause of severe anemia also. Use of oral progesterones is strongly recommended. Any patient who has had multiple blood transfusions because of severe menstrual bleeding and does not have control with large doses of progesterone. I had one person who was even suggesting hysterectomy if they finished their family. The correction of bleeding should be with fresh frozen plasma. One should avoid trying to give IV vitamin K as the first thing. If you give IV vitamin K, that will be many, many weeks before you can keep them on oral anticoagulants. The correct thing to do, if you've given it, supposing the patient had an active CNS bleed, things were desperate, then you have to be willing to do INRs just like you do for a patient who's just had a surgery. For the next 8 weeks, you will not be able to judge how much they need. They may be completely resistant. They may require heparin. It's good to start heparin and then start doing INRs with oral anticoagulants. So fresh frozen plasma, and if the INR is more than 6, you can give oral vitamin K. If the patient is bleeding and it is more than the out of range, you can give oral vitamin K. That tends to cause less problems. I think we have discussed ball thrombus, and you've all seen obstructions. We are recommending that patients, if they give a history that they have not been taking their anticoagulants, and if it's a CNS emergency or if it's a major ball thrombus, do not wait for INR reports, do not do a CT scan, treat it as embolism. Any patient who has not taken drugs for 10 days for no good reason, it's not that he was bleeding, it's not that he had hepatitis, he just stopped it and he has a stroke. This is not the time to say I have to do a CT scan, this is the time to treat. Every minute is important. As I said in the beginning, patients have to be assumed to be in stage B, C or D of heart failure. They need beta blockade and ACE inhibitors if they have a mitral valve prosthesis. It's not enough to wait till they have CHF and then start it. They should have regular blood test monitoring. We are recommending that they should not be made to exercise too much. It's better to rest than to exercise. And it's better to take up jobs which are sitting jobs like computer and etc. They should be actively encouraged to go into these vocations. In conclusion, we need to make NABL accredited labs available to these patients, and if it is not available, we should be thinking of other options like home INR kits and bioprosthesis. We are trying to standardize the time at which INR will be done, the way the dose will be titrated when it is high. We are insisting on the use of antithrombotics and immediate treatment for major embolism without waiting for CTs, etc., if the patient has stopped drugs. We are asking them to reduce the use of bridging therapy because bleeding may be common after routine surgeries if heparin and low molecular weight heparin is used, and to try to manage an episode of bleeding without intravenous vitamin K. Thank you.